Oh,
Jyotsna, shall we start?
I think yes, we should. Asmita ji, can you please make the chat live?
Live, and it's live.
Okay,
Okay.
all right.
Thank you. Good morning, everyone. Myself, Dr. Saraswati Nashi, and Dr. Jyotsna AS are privileged to have you all today to the fourth series of the Young Neurology Forum webinar. So we have our esteemed moderators here, Professor Ravindranath, who is a professor of neurology and epilepsy specialist at NIMHANS, and Professor Aditya Nair, who is a professor of neurology at CMC Vellore. So the theme for today, as we now told, it's epilepsy. I would like to invite Professor Ravindranath sir to please take over the proceedings.
yeah. Thank you, Dr. Saraswati and Dr. Jyotsna, for giving this opportunity. So, welcome all the delegates for this talk on Sunday. So, today we have two good speaker, Dr. Rutul, will be presenting on his experience on MRI in epilepsy evaluation. And Dr. Rutil did his DM neurology from NIMHANS, and following which he did fellowship in epilepsy at Amrita, and currently is practicing at Ahmedabad KD Hospital as a consultant neurologist and epileptologist. He is very enthusiastic from the time of his neurology residency, and is very interested in research, as well as he picked up a lot of engineering stuff like post-processing of MRI and all in short time, and is able to use for the patient care very well. And Dr. Rutul, welcome, and I can start the presentation. Dr. Vinay is my colleague during residency time in NIMHANS, and after completing his DM, he is currently practicing as a consultant neuroradiologist at Apollo BJS Hospital, Mysore. So welcome, Dr. Vinay, and both of you, without wasting much time, we can start the presentation. Thank you.
Thank you very much, sir, for the kind introduction. And thank you very much, Dr. Saraswati and Dr. Jyotsna, for giving me this opportunity to present my experiences on neuroimaging and epilepsy. So I'll start sharing the screen. So today I'll be discussing about neuroimaging in epilepsy. I'll be discussing. So the scopes of the talk will be, I'll be discussing about introduction about why neuroimaging is important, what MRI sequences are important for us, what acquisition protocols should be used, what is MRI post-processing. I'll be introducing briefly about that. And after that, we'll be discussing PET scans, SPECT scans, SysCom, predominantly for pre-surgical evaluation in epilepsy, following which we'll be discussing two interesting cases. So 1/3 of the epilepsy patients are refractory to medications. And out of those patients, a large number of the patients are focal epilepsies. And focal epilepsies, if they are refractory, there is a good chance that if a epileptogenic zone is found out, we'll be able to properly tailor the management for the patient and maybe provide a surgical resection or ablation option to the patient. So identification of the epileptogenic zone, as I mentioned earlier, it provides a chance in surgical intervention as well as subsequent drug freedom and seizure freedom. So first of all, I'll be discussing about MRI brain. So why MRI brain is important and why acquisition protocols is important. Because certain times when we see that, when we take a history, we find out that a patient has mentioned that the patient has a focal epilepsy, but MRI has been reported to be normal. So certain times, if the acquisition protocols are not very accurate, there is a chance that the small lesions can be missed. So what should we do in a way that acquisition protocols are standardized and the lesions are not missed? So there is a harmonized neuroimaging of epilepsy structural sequences. This was given by ILA task force in 2019. So they made sure to show us which all images to be included so that we don't miss out on the lesions. So it is a three-dimensional sequence with isotropic voxels of 1 millimeter. What do you mean by isotropic voxels? Voxels are like pixels when we talk in terms of the screen. So, and what do you mean by isotropic voxel and what is three dimension? So there are three ways MRI acquisition can be done: axial, sagittal, or coronal. So when we mean by isotropic voxel are that these are cubital voxels. So these are 1 millimeters in coronal section, axial section, as well as in the sagittal section, so that we get a three-dimensional view of the entire brain. So what are the advantages of harness protocol? That if a young neurologist who is practicing on tier 2 or tier 3 cities after finishing DM neurology, or the early career researchers, what happens is that when they go back to their city and they start practicing, they realize that we want to practice what we have learned during our residency. And sometimes it is difficult to get that. So we are not able to find the accurate protocols which we learned during our residency. So what can be done? There is a harness protocol. You give it to our imaging center. It can be done on 1.5 Tesla scanners as well as 3 Tesla scanners. It is applicable to children as well as adults. It provides complete brain coverage, as I discussed earlier. And there is no need for operator-dependent slice angulation, so that this sequences are completely operator independent. And we can reformat it in any plane without loss of resolution. And there is improved signal to noise ratio and tissue contrast. So what are the sequences which are very important and what are included in harness protocol? First of all, most of the centers are doing T1 volumetric sequence, that is 1 by 1 by 1 millimeter voxel. That is what we need to tell the neuroimaging technician. And there should not be any interslice gap. So to mention that there should not be interslice gap is very important here. Certain centers, 3D flare is not done as a part of epilepsy protocol, and we should insist on the same. I'll come back to that. Why it is important to have 3D flare 1 by 1 by 1 millimeter voxels. And second thing is that T2 coronal is done everywhere along the long axis of hippocampus, but we have to also ask to cover the entire brain when we are doing T2 coronal along the axis of hippocampus, because certain times temporal pole are missed, and as a result we miss temporal encephalocele, which are one of the important cause of drug resistant epilepsy. Another thing which we need to make sure is that there should not be any artifacts. If the patient is uncooperative and we are suspecting a surgically remediable epilepsy, then sedation, we should use sedation generously in such patients. Adequate head padding, patient counseling about minimal movement is very important. And central position of the head is important. So this is the protocol which is recommended. So 3D MP-REG image, 3D flare, T2, DWI, and GRE specifically for cavernomas. And the acquisition time, as we mentioned here, the epilepsy protocol usually takes around 20 to 25 minutes for acquisition, if it is going smoothly and there are no hiccups in between while acquisition. So now this is one example which I would like to give why T1 volumetric sequence and 3D flare is important. So there are two images labeled here. One is MRI positive. The arrow mark shows that there is gray-white differentiation, which suggests that there is a probable focal cortical dysplasia, which is the reason for refractory epilepsy. The second image, which is labeled as MRI negative, we are not able to find any lesion there. These two are two separate patients. So one patient is T1 MRI positive, focal cortical dysplasia. Second patient is T1 MRI negative. In such cases, if we do a 3D flare, we can pick up the lesion. So at the same section, I'll be showing the flare images of the same patients. So in the MRI positive patients, we are clearly able to see that whatever focal cortical dysplasia was seen on T1 is very apparent on flare. But in the MRI negative patient, which was labeled earlier on T1 image, with this flare image, we are able to diagnose a dysplasia, which was not very apparent on T1 image. And that is the reason 3D flare volumetric sequences are very important while we are considering focal epilepsies or structural epilepsies. So I discussed a lot about 1 millimeter cuts, which are important. Why is it important? And this is one of the reasons I insist that all of us, while we are evaluating an epilepsy patient, we should insist on looking at these images on our console. We should scroll through the images and not look at the images which are provided by the imaging center, because these are the limited images. And even if it is reported as MRI negative, it is always better for us as neurologists to go ahead and see the MRI ourselves, because we have more information about the clinical picture. We have information about the video EEG. We have information about the lateralization, etc. And in epilepsy, if it is reported as MRI negative, it is always better to have a biased point of view as a neurologist. If we have a video EEG lateralization and localization, we should specifically look for that area to see if there is any lesion or a surgically remediable lesion available there to find out the cause. So in this 3D flare image, which is reformatted at 3 millimeters, we are not able to find any lesion which is very apparent. But if the same patient, if we go ahead and look at 1 millimeter cuts, so here the arrows are marked, we are clearly able to see the dysplastic lesion, gray-white differentiation, flare, hyperintensity, which was not very apparent on this 3 millimeter cuts. So that is why reformatting at 1 millimeter cuts is very important. And that's why 3D flare is very important. Now, coming to T2 coronal sequence. Why they said that in harness protocol, T2 coronal along the hippocampal axis is very important? We see here, one is labeled as MRI positive and second is labeled as MRI negative. The top images are T1 images, where in the MRI positive patient, hippocampus is shown, there is some atrophy, and there is probable temporal sclerosis there, which is very well picked up on T2. But the patient which has been labeled as MRI negative on T1, on the right side, we are able to see that there is T2 hyperintensity at the hippocampus, which may again suggest that there might be hippocampal sclerosis in this area. So the lesions which are missed on T1 can be picked up by T2 coronal if they are done well along the hippocampal axis. So one more tool which we have is that hippocampal volumetry. Most of the centers now provide hippocampal volume either by manual calculation or automated calculation. And if we are able to calculate the hippocampal volume, we can predict that one side is slightly lesser or whether the volume difference between the two hippocampi is significant or not. And there is an objective measurement which has been reported in 2017, which is called hippocampal asymmetry index. So what is hippocampal asymmetry index? Volume of left minus right divided by volume of mean. And the cutoff which was established in that study was that if it is 0.1355 or higher, we can have a better confidence when we are offering a surgical resection or surgical intervention to the patient, given, this is very important, that this isolated finding may not be of clinical significance until and unless we are suspecting that this patient has seizures which are originating from this region, and the T2 and flare images are still showing us that there are significant lesions. Isolated hippocampal volume has no significance at all. This is just an additional tool for us, which helps us in getting a better confidence or providing a better counseling or providing better options for the patients, objective options for the patients in such cases. Now, I would like to discuss about something about MRI post-processing, which is not very widespread available as of now, but it has been used at multiple centers since 2000, 2005. So what is MRI post-processing and why is it important? So as we know, focal cortical dysplasia is a neuronal migration disorder. So what happens is that the normal cortical laminar architecture gets disrupted, because of which there are aberrant neurons. Those aberrant neurons increase the cortical thickness sometimes, and those neurons are they retain the epileptogenicity and they retain the network connectivity. So those aberrant neurons or loss of normal cortical lamination may lead to seizures, which are often refractory to medication. And as a result, it is very important to not miss a focal cortical dysplasia while we are trying to while we are doing a pre-surgical evaluation. So FCDs, as we discussed earlier on T1, we can pick up on flare reformatting. Certain times what happens that while we are trying to discuss amongst our team, some people may agree that we are able to see a subtle gray-white matter differentiation. Certain doctors may not agree because these findings are very subtle. And we would like to have something with us which can help in enhancing the subtle findings so that which increases our confidence level for offering a surgical resection to the patient. Because if the team is not agreeing on the findings, then it is not a wise decision to offer a surgical option to the patient. So on MRI, FCD is characterized by variable degrees of cortical thickening or gray matter and white matter differentiation. And we can see a hyperintense signal on flare images certain times with respect to normal cortex. So what are MRI post-processing? What are the images option available? So it is called texture imaging. So what is a texture? The texture of an image can be described by the brightness and darkness of the pixels or the voxels, what we discussed. So it is a mathematical technique. Say, for example, we see gray matter as gray, white matter as white. So while we are trying to calculate the intensity difference between the two, what texture image does is that gray matter becomes more gray, white matters become more white. So the difference can be more apparent while we are looking at those images. These are not new acquired images. These images are just the processed images, mathematically calculated images from our standard T1 which has been acquired. And these all post-processing can be done with the help of certain tools, which I'll be discussing later. I'll also be discussing how you can acquire those tools. So these are all T1 generated images. So how do they look? So we are able to see here, this is a normal gray-white matter transition which is shown. And in the middle image, we are able to see that the transition between gray matter and white matter is not very clear. And this is at microscopic level. Certain times it is apparent on naked eye and we are able to pick up on MRI. Certain times we need some enhancement tools to confirm our suspicion. So this is what gradient map looks like. Right now it is shown in gray and white, but we can always change the color just like the PET scan. So this is how the gradient matter, gray matter thickness map and gradient map looks like. So what should we look in those images while we are trying to assess? Say, for example, we are able to see on MRI that on the right frontal region, there is gray matter, white matter differentiation, which is very apparent on gray matter thickness map. In gradient imaging, what happens? Because the gray-white matter differentiation is lost, whatever the ribbons we are seeing in gradient imaging, that ribbon will become dark, and in that area, the ribbons will not be visible clearly. So one image is gradient image, another is ratio map. So on the basis of this image, we can just help in enhancing. Mind you, I know that it is very difficult to understand at this point of time while I'm trying to explain, but there is a learning curve. Once we start looking at the images and comparing those images, more and more confident you get. And there are certain images which are available online as well, gray matter, white matter. You can directly download it. So see here, on the left side, the ones which are marked in white dotted line. So we are able to see on flare in that area that there is a gray matter, white matter differentiation, which is very subtle. This is a gradient image. As we see, the yellow colored ribbon is lost in that area. And this is what we look at in gradient map. And one thing which is important while we are looking at gradient map is there will be certain false positives which we'll be looking at. So we cannot just look at the gradient map and then retrospectively go back to the flare image or T1 image. It is very important. We should have our suspicion on T1 image. We should have a suspicion on flare image. And then just to confirm that our suspicion is correct, we should look at the gradient image or ratio image. And one more thing which is very important, what we see in flare images as well, that if we are finding something abnormal in gradient image in axial section, it is very important that it should be present in sagittal section as well in coronal section. So if all three sections at the same point are showing abnormality, then only we can consider it abnormal. Otherwise, we cannot label it as abnormal. So why to go through all these things? Because certain times when a patient is referred to you as MRI negative epilepsy or focal epilepsy, if you do a harness epilepsy protocol, there is a chance that it may reveal a lesion in 30 to 65% of those cases. These are all documented statistics which I'm quoting. And MRI plus image post-processing increases the sensitivity to 70% of those MRI negative patients. So that is why I insist on harness protocol to not miss a lesion, and image post-processing to enhance our diagnosis. Why all these things? Why to find out a lesion? Why is it important? So that we can prognosticate the patient about what are the chances of seizure freedom depending on the pathology which we are suspecting. So now coming to PET scan. PET scan is an important tool in evaluation, pre-surgical evaluation of epilepsy patients. So what do we look in PET scan? First of all, the PET scan should be interictal PET. The patient should not have had seizures in last 24 to 48 hours. Otherwise, it can confound our report. Hypometabolism is the hallmark, or is a surrogate marker, we can say, for an epileptogenic zone where it helps. PET usually denotes the functional deficit zone. So it denotes the seizure onset as well as the area of spread. So PET hypometabolism is usually larger than the lesion or the epileptogenic zone, but it helps in focally in defining or localizing the epileptogenic zone. So what are the PET acquisition parameters which are important for us? So preferably if you have a digital PET, please go ahead with digital PET. If not, a routine PET works. Thin cut CT should be done. And we should insist certain centers, because most of the PET centers or nuclear imaging centers are used to doing whole body PET for all the patients who are coming there. So our epilepsy patients are coming once in a while for the PET scan. So when you are sending to a PET scanner, you have to insist that only PET brain is important. Whole body PET may not be of significance if you are doing it for epilepsy. Second thing is, because we are not doing whole body PET, we can ask them to do the brain PET. If the acquisition time increases, we might get better outcomes. Second thing, there is a routine practice to give CT contrast to all those patients who are undergoing PET scan. So CT contrast, the routine PET centers, they do that because they want to look at tumors. So unless and until we are suspecting tumor, or we are suspecting, say, for example, tuberculoma, neurocystic sarcosis, we should not ask our patient to be exposed to CT contrast unnecessarily, because in epilepsy, it may not significantly enhance the value of our diagnosis. And as I mentioned earlier, preferably 48-hour gap from the last seizure event to avoid ictal PET. Discuss with your radiologist that we want to look for a specific hypometabolism, because routinely they report hypermetabolism when they are reporting. Say, for example, if they're reporting 10 PET in a day, most of the times for tumors and all other reasons, they are looking for hypometabolism. In our case, you specifically ask that you want to see a hypometabolism which is coming out from the PET scan. So this is an example of the PET scan of one of our patients. We are clearly able to see a hypometabolism here, which is marked. And now this is PET MRI co-registration, so that we can go back and look at our MRI image. We can co-register this PET on either our FLAIR scan or T1, so that it is easy to pinpoint whether exactly there is a sulcal hypometabolism as well. Because certain times in epilepsy, bottom of sulcus dysplasia, we may not see a lobar hypometabolism. We have to look for a sulcal hypometabolism in case we are suspecting bottom of sulcus focal cortical dysplasia. And how MRI post-processing helps? MRI post-processing, something called PET asymmetry index. It helps us in exactly focusing on the area which is maximally hypometabolic. So this is how MRI post-processing helps. The area which we are seeing earlier on PET scan as hypometabolic. Now we can see on T1 or FLAIR which area is the maximal hypometabolic zone. It does not mean that we have to resect that area. It just means that there is a possibility that pathology is somewhere in this area of PET hypometabolism if it is correlating with the clinical findings. What I'll briefly discuss about SPECT and Syscom, it is not widely available, but it can be used predominantly only for lateralization. The SPECT scan or Syscom predominantly helps in lateralization, sometimes in lobar localization, but not more than that, unlike PET scan. So in SPECT scan, what is done? That SPECT dye is injected at the time of seizure, at the onset of seizure. Ictal SPECT is calculated. After some time, once the patient is seizure-free, we do interictal SPECT. Ictal SPECT shows hyperemia. It will show hyperactivity. Interictal will show hypo. And we have to subtract them from each other. That is what is Syscom. After subtraction, so this is the flow chart which I'll show, that MRI is done, ictal SPECT is done, interictal SPECT is done. Ictal and interictal subtraction is done, SPECT, and that is fused on MRI, that is Syscom. So subtraction interictal SPECT co-registered on MRI is Syscom. It is very important in the evaluation of MRI negative epilepsy. Sometimes when we are not able to lateralize it, certain times most of the centers do this when they are trying to do a stereo EEG or they want to have some idea about whether that localization is correct or not. But it itself does not stand a significant value because it does not help in localizing the epileptogenic zone. It just helps us in propagation of the seizure. Another tool which we have in pre-surgical evaluation is fMRI. Most of us know what is fMRI. It is identification of the location of language, memory, and other critical functions. It is non-invasive. The areas get activated when we perform a task, and we get something which is called a bold signal, which we see while performing the task. So patient is an MRI, patient performs tasks like language task, motor task, and we see the activation in the brain, the area which is responsible for that. Why is it important? Because if the bold signal activation is more than 10 millimeters from the probable resection margin of our patients, then the outcomes can be better. But if it is very close, then there is a good chance that patient may develop a deficit with the surgical resection. So it helps in prognosticating the patient and counseling the patient. Certain times a decision about awake surgery is also made on the basis of this fMRI reports. This is one of my patients who had a cavernoma close to the motor cortex in the left frontal region. So we are able to see the bold activation signal, which is far away from the cavernoma here. This patient underwent surgical resection. Even the leg area, lower limb area signal activation was far away from the cavernoma. So this patient underwent resection of the cavernoma because the patient had refractory epilepsy. The patient is seizure-free. So now I'll be showing how all the tools which we used can be implemented in pre-surgical evaluation by giving an example of the case which we have. So this is the first case. 15-year-old boy, right-handed, first and only child to the parents, normal delivery, no perinatal insult. The patient had seizure onset at 2 months of age, and subsequently he was also identified to have speech delay. No febrile seizures or status epilepticus. He has average scholastic performance. He is independent. So age at onset of seizures is 2 years. And since last 1 to 2 years before our presentation to us, he had daily seizures. He was tried on multiple anti-seizure medications, appropriate dosages and combinations were tried, but he was still refractory. He had daily 1 to 2 events. And what were the events? The events were always out of sleep. He had no aura. This was the historical semiology which was given to us by the parents. He was hypomotor, he was staring, hyperventilating, and unresponsive during the event. So we went ahead and admitted him for video EEG. I'll not be showing the videos to save time. I'll just tell what happened during the video EEG recording. So video EEG captured the event with initial chapeau, along with axial rocking and distal stereotypies. So we are suspecting a probable frontal lobe epilepsy, but the video EEG did not help. The video of the clinical part of the video EEG did not help us in lateralizing the event. So it was lateralization was unclear. Localization probably was frontal lobe or cingulate epilepsy. So I'll be showing, he never had secondary generalization. Maximum seizure-free interval was 2 to 5 years. He was evaluated previously. Routine investigations and MRI was reported as normal. So this is one of the example of MRI negative epilepsy, which was reported with 1.5 Tesla non-harness protocol MRI. So as I marked, we saw some sharp waves which were rare in sharpened spikes in left frontal region, FP1, F3. Again, same. Similar. This is the interictal EEG. Again, interictal EEG, FP1, F3, F3C3, FZCZ as well. This is the pre-ictal EEG. So I'll be showing the ictal EEG now. The artifact, movement artifact which we are seeing is the one where the seizure started. This is the seizure propagation. We are able to see rhythmic polymorphic activity in same area where we saw the interictal discharges. There are significant artifacts as well because the patient had axial rocking and distal stereotypies. The event lasted for around 15 to 20 seconds, and there was a sudden onset, sudden offset, no post-ictal slowing. I'll show another ictal EEG. This is pre-ictal. Same, this is the movement artifact is where the event started. Immediately after that, we were able to see a rhythm evolving over left frontal region. Again, abrupt offset. So with this history, we thought that we have a patient, 15-year-old, who started at 2 years of age, daily multiple events, out of sleep, so probable frontal cingulate with a lateralization towards left frontal region. This is what our pre-MRI hypothesis was. The MRI 1.5 Tesla was done. It had T1 images. It did not have 3D flare. So we repeated the MRI. So I'll stop screen sharing here. And I'll show the images now. My screen is visible now?
Yes.
Vinay sir, could you please help? I mean, we would like to discuss about the MRI.
Yeah, in this one, again, I might be biased, but I don't see anything which is very obvious here. So I don't know. Means there is some we had discussed before actually that
yes, sir.
There is very subtle asymmetry of the left frontal region, but again, this is very difficult to actually put it as a report based on these findings only.
Yes. So this is T1. We had a probable suspicion here that T1 we had gray white matter differentiation. I'll show the flare as well. Again, subtle finding here, probably. So would you like to comment on that?
Yeah, there could be some amount of gray
Yeah.
blurring. The junction of the gray white matter might be blurred, but it's very difficult to be very confident about this.
Yes, the same thing happened with us as well. We were also split into groups about whether this was a lesion or not. So we thought we'll go ahead with the interictal PET scan. Luckily, we were able to get a 24-hour window from the patient because patient had daily seizures and we did not achieve seizure freedom. But because these events were less, were for lesser duration, 10 to 15 seconds, we tried to have the maximal time difference between the last event and we did the PET scan. So this was the suspicious area, sir, which we saw. Probable sulcal hypometabolism here.
Do you show it with an arrow, please, Dr. Ratan?
Is the crossbar visible here, this one?
Yes. Now it is, yes.
So axial, sagittal, as well as coronal, we had a suspicion that probably, this part, same, axial, coronal, and sag. So again, PET increased our confidence. So we went ahead with PET asymmetry. I did gradient and texture image. I'm not showing it here because it did not help. And usually gradient image and ratio image does not help usually in cingulate epilepsies because it is too central. It is usually bilaterally symmetrical. That is what my experience has been. So PET asymmetry picked up this. So this showed the area of the maximal hypometabolism. So if I hide this, this is the same area where we are suspecting the lesion. So one point I would like to highlight here is that we need to have a pre-PET hypothesis where the lesion probably might be. Otherwise, if you are seeing a PET hypometabolism somewhere else and you don't have a pre-PET hypothesis, then you are again not very confident. So we had a pre-PET hypothesis about the lesion being here. And probably the PET was showing and PET asymmetry showed the lesion. And it was clinical features as well as video EEG was helping us in localizing. So we thought about going ahead with the resection. Ravindranath sir, would you like to comment on that anything?
Yes, it is a very good pickup. I think previously all over the world, these kind of lesions, people were doing stereo EEGs and confirming. But after that, now everyone got confidence. If we are able to pick up these kind of subtle lesions, directly going ahead for surgeries, reducing the significantly requirement for SEEGs has come down with these post-processing techniques. So once you express the doubt and one of the other post-processing tool or PET or any PASCOM, any of these techniques are supporting, then we are directly going ahead with surgeries. So it's a very good this thing for everyone. Yeah.
Yes. So we have a rule because we are a relatively new center and we don't work in the institute. So if two epileptologists and two neurosurgeons who work as a single team, so all four of us agree, we go ahead with the surgical intervention. Otherwise, we don't. So here we had a consensus decision that we should go ahead with the surgical intervention. And that's what we explained the patient, and patient was having significant seizure burden as well. So now one more thing I would also like to highlight that with these tools available, all the centers may not have robotics to go ahead with precision treatment. So what we suggested and we went ahead with just to help the neurosurgical colleagues was that we can mark these areas which we were suspecting like this. And these marked areas can be converted to DICOM images and you can feed any neuronavigation software. So when the surgeon is operating, they see this white dot here. So we can always remove that because certain times during the surgical intervention to exactly localize and lateralize whatever has been discussed earlier, sometimes if we have these tools available, it becomes slightly easy. So with the available tools, we can always do this. We can we can mark this image like this, and we can give it to the surgeons so that they can have it in the neuronavigation tool. It can just help them aid, just maybe 5% ease. 5% ease in localizing. So we went ahead with the surgical resection, and the patient was diagnosed to have focal cortical dysplasia type 2A. It was an ECOG-guided resection. The significant spikes were noted. I'm not showing that here. I'll stop screen sharing here. And I'll start again with my slides. So this was the lesion which we discussed. This was a PET scan. In PET hypometabolism asymmetry helped us. Eco-guided resection was done. And this was FCD type 2A. The patient is seizure-free now. It has been around 9 months to 1 year. Final diagnosis is left anterior cingulate focal cortical dysplasia. Now the second case, ma'am, do we have time of 10 minutes?
Till 1
Yes,
minute. Yeah. Yeah. Another most important clinical feature that you told was no secondary generalization anytime in the life. So I think
yes,
this is
yes,
one
sir.
of the most important feature for the primary cingulate epilepsies. Okay. So
Yeah.
primary cingulate generally never generalizes. That is one of the universal statement kind of thing. So that is also concordant with your lesion. Yeah.
Yes. We have a second case. I'll quickly wrap this. 21-year-old lady, completed 12th class, age at onset 17 years, duration 4 years, frequency once in 2 to 3 months. She started with nocturnal sleep events out of sleep, but now she had daytime as well as nocturnal events. The aura, she had a vertiginous aura, followed by deja vu, certain times, not always. She had impaired awareness, unresponsiveness. She was hypomotor, not responsive, and she was amnestic about the event. Historically, she did not have any lateralizing features, but video EEG additionally provided the information about the right hemispheric lateralization. So we went ahead with video EEG. This is the interictal EEG. We were able to see sharp and slow waves along right temporal and subtemporal chain of electrodes. Again here, it is not very anterior temporal, but it has been there. The rhythmic slowing was also noted. So vertiginous aura was the odd point for us. Otherwise, we initially thought that it would be a classical temporal lobe epilepsy, but there was no any history of febrile seizures or anything else. So we went ahead and did the MRI. So this was the ictal EEG. Initial artifacts. Through the artifacts, we were able to see a rhythmic monomorphic theta range activity evolving over right temporal region. Again, I'll show this. Yes. Then offset. Again, this is another ictal EEG. So investigation. I'll just open the MRI. I'll stop screen sharing.
I have a question for Vinay sir, while Rutul is trying to change this screen. So you have been trained at a national center of repute and you know all the post-processing techniques, but sitting at a tertiary care hospital, but not at an institute, where the availability to you is at this point a 1.5 Tesla MRI, say, and there is nothing more to offer. And do you still think we can make the most of a 1.5 T MRI and with the right sequences and then still get a lesion? Is it still possible?
Yeah. So basically, the thing is that we need to know that actually the basis of epilepsy imaging is not just to look for what your focal cortical dysplasias. So focal cortical dysplasias are the hard to find lesions. So unlike that, there are many other lesions which might be slightly more obvious even on a 1.5 Tesla. So the difference between a 1.5 Tesla and a 3 Tesla is that it's the signal, the SNR, all those things are very important. Yes, the pickup chances in a 3 Tesla is much better, but still you can, in a reasonably well performed scans, even 1.5 Tesla offers a good pickup chance. So again, the focus here, as Dr. Rutul said, is the focus should be on the standardization of the techniques. So there are many other basically pathologies which can be just picked up with this, even a 1.5 Tesla, like something like a scar, vascular malformations, low-grade tumors like leads. All these things can cause epilepsy. They can also cause drug-resistant epilepsy, which can be picked even with a 1.5 Tesla. You don't need a 3 Tesla MRs for that. And what the advantage of a 3 Tesla MR is that, so our protocol, what I feel is right would be to do, because we aware it's a resource put setting what we have. It's not possible for every patient to subject them to 3 Tesla MR at every point of time. So what you can do is that you do when the patient comes first, especially in the first onset seizures or probably a reasonably well controlled seizures. So you do it with a 1.5 Tesla. So if it is negative, then if the drug is probably, if he continues to have a drug resistance epilepsy, then you subject him to a 3.3 Tesla MR. But the protocoling usually remains the same and nothing else. So I think based on that, I think 1.5 Tesla, yes, for us, it's reasonably works well. That's it.
Yes, sir. That's exactly what, because young neurologists we are going out, we are getting very well trained, but we are going out and sitting in centers which are relatively resource limited. So, yes. So, Ravindranath sir, how important do you think PET is for evaluation of a case for epilepsy? Dr. Rutul beautifully demonstrated how PET aided the diagnosis in the case with an early onset infantile epilepsy. But in a general scenario, you work in a setting where you have the options of multimodal imaging. And do you do a PET in all suspected cases of focal epilepsy? How do you choose which patient goes for the PET? And what's
Yeah,
the ideal time to do it, sir?
PET in our center, since it is available, we do for all the patients, but that doesn't mean that it is required for all the patients. So mainly it is in pre-surgical tool, it is actually for represented for functional deficit, not for the picking up the lesion as such. But we use it for picking up the lesion many times, especially the way Rutul demonstrated. Many of the BOSDs, which are like previously all were thought as MR negative, PET has changed the game. So many times previously, which we were thinking negative, once you see the PET and go back and see the MRI, you will be able to find the lesion in most other situations. So that way it is really helping in refractory epilepsy patients. But if the lesion is very clear, still also do you need to do means that will help one way. Sometimes we may have multiple lesions, like tumor can be associated with FCD, and you can have when especially in HI we have problem of multifocality. If you see only gliosis in the occipital lobe, and if you see significant hypometabolism in the ipsilateral hippocampus, so in the PET, so that it will help you that the network is not just confined to only occipital lobe, maybe hippocampus also over time it might have got affected. So even though lesion is clearly present, in those situations it will help us to think about the extent of network. And especially in FCDs, another thing is the you, even though you know the lesion, you will not know the exact boundaries of the lesions in many times, especially 1A, 2A, these FCDs. The boundaries are always difficult in the structural MRI. So if the PET shows extensive hypometabolism, then our margin of resection should be little liberal, and it should depend on ECOG and ultrasound intraoperatively. So those things will be helpful. So that way PET can be used to improve the outcomes. But if resources are limited, especially unilateral MTS without any red flags, or if you have a tumor without any red flags, that time may not be mandatory. But if it is available, please, it's better to do. Even in best of the centers, we know the epilepsy outcomes are only 70 to 80 maximum. So that means another 10-20% everyone is making mistakes, not the resource limited settings. That means any additional investigation, providing any additional information, should be done before putting the knife on the patient's brain. Even if it helps 1 in 100, that is really going to be helpful. That is how we just look into that.
Absolutely, sir. Good. Thank you. Rutul, I think.
Yeah.
Yes.
So I'll just remind again, the patient had vertiginous aura. Following that, the patient had probable lateralization towards right. We saw right temporal and subtemporal chain of electrodes showing interictal as well as atrial discharges. Our suspicion was right temporal lobe epilepsy probably, but the vertiginous aura was odd in that case. So, sir, do you want me to scroll? Vinay, sir, do you want me to scroll T1 or flare images here?
Yeah, I think it's better to scroll show the flare, 3D flare. Chance of pickup with a 3D flare might be much better.
I'll go from top to bottom in the axia.
Basically, I'm biased though, probably, but still
Yes.
there is some area of abnormality in the right temporal region. So
Yes.
any cases which we report, so it's always that we make sure that we have an idea regarding the clinical background. The
Yes.
EEG localization is a must. So whatever
Yes,
the
sir.
cases which have been missed previously are usually because there is no clinical correlation. So unless
Yes.
you have a clinical correlation, the EEG, the clinical semiology, all matches, I think yes, probably the pickup chances on an MR would be significantly better.
Yes. Thank you, sir. So yeah, the traditional teaching says that we should be unbiased initially when we are looking at the MRI. But with epilepsy, once we have video EEG and EEG findings, it is always better to be biased, as you correctly put it, sir. So this was a probable area which we suspected. And on T1 also, there was some cortical thickening, which was observed. I'll just go through that. So this tool which I'm using is called ITK Snap. It is freely available. Anyone can use it. You just have to upload your DICOM images. And you can just ask the imaging center to send you DICOM files on your email. You download it, upload it on this, and you can see all the images here. So this was the area which we thought cortical thickening was there. Suspicion, we still wanted to confirm with PET scan. We did PET. There was an area of hypometabolism here. But one thing which we had another doubt was that even though mesial temporal looked all right, we thought there is probable hypometabolism in that area too, which I am not sure. So I mean, that was our consensus at that point of time when we were discussing that. So we were still not sure, but we were sure about the lesion. So as Ravinath sir correctly pointed out earlier, that we have to be careful about two lesions as well certain times. So we did PET asymmetry at that time. But let me go to GMAP first, because as I discussed MRI post-processing techniques, so I just wanted to demonstrate about how it might help the area. So this was the FLAIR image.
So how much time does a post-processing take on an average? And
post-processing usually of MRI, this texture and
yes.
gradient image, it takes approximately 30 minutes on a good computer with a good RAM and those things. And PET post-processing usually takes 1 hour or more.
And that process is initiated by who? Is it the radiology technician, or is it the neuroradiologist, or who does the post-processing?
It varies from center to center. Most of the times it is by an engineer or software engineer who knows about how to use MATLAB or an SPM toolbox. But it is not very difficult for us as neurologists to learn those things. There has been a learning curve for me for last 3-4 years. We are still trying to exact those techniques. But if anyone is interested, we can always do it. In our hospital, I and Dr. Abhishek, we both work together. So we share the work and we both do it ourselves at this point of time.
Is the initial thing blinded to between you two?
Which one, sir?
The interpretation, is it blinded between?
Sir, for MRI, sir, how our workflow goes is that once we see the patient in the clinic, we make a probable diagnosis about what type of epilepsy does it look like. And then on the basis of clinical history, we try to find a lesion on MRI, if possible. And then we do MRI post-processing if we have a doubt. So we directly don't do post-processing for all the patients. If we have a doubt, we do post-processing on the basis of clinical history alone. Then we admit the patients for video EEG, because usually there is a queue for video EEG. MRI can be done immediately. So if we find a lesion, so we are confident, so we know what to look in video EEG and if something will be available. But if it is not, then we do video EEG, and then we again go back to the MRI to see if we are able to find anything. If not, we go ahead with texture and ratio image, but certain times they don't help a lot. Then we do a PET scan if we have a suspicion, and that is how we go ahead. Ultimately, what happens is that once I and Dr. Abhishek, we both epileptologists, we have prepared the case and everything has been done. We sit with our surgeons after neuropsych assessment and everything. So our duty is to make sure that the surgeons are convinced that whatever we are seeing is a lesion and we are not hallucinating. So if the surgeons are convinced, because we will always be biased, as we know. So surgeon is the one who has to operate, and we always want an unbiased opinion from our surgeons. So if we are able to convince our surgeon that there is a lesion, then we probably go ahead, otherwise we don't. And there are certain times when they don't agree, and we are really glad that we have surgeons who don't agree with us.
So all this happens when the patient becomes drug resistant, or is it that you're an epileptologist, a drug resistant patient is coming to you? in the first few months of diagnosis, what is your inclination to do all this, or would you wait until there is things are going in the direction of a drug resistant mode? At what
No,
point of time
we
do you plan
usually
this?
go by protocol. So we see who has referred the patient to us, and if adequate medications has been trialed on and appropriate medications has been trialed on the patient. So on the basis of clinical history, we will have an idea. Say, for example, the gentleman with daily multiple events, he was trialed on multiple anti-seizure medications. We always adjust till the time the patient comes for video EEG. We see for a couple of months after adjustment whether it is working or not. But usually in such cases, when we know that patient is having daily seizures and all the medications has been trialed on, we prime them that video EEG might be necessary in such cases. But we have to go strictly by rules. It is not that one anti-seizure medication, we see a lesion and we operate. No, we have to go by guidelines. If the patient is refractory to medications, to more than 2 medications, and it has been trialed appropriately, then only we discuss about pre-surgical evaluation. Yes, sometimes we do video EEG if we are not sure about the semiology of the patient, or we are not able to exactly characterize the event on the basis of clinical history, or we don't have a home video recording of the patient, just to make sure that those are true seizures if the patient is having daily seizures or once in a week or once in a month seizures, and just to see how interictal EEG looks like. Otherwise, we reserve the pre-surgical evaluation only for those patients who are refractory to medications. So one interesting thing, I'll just quickly wrap up. I think I'm exceeding my time. So this is the ratio image which we did. So this looks scary, but it is not. So in ratio image, we have to look at usually it is a comparison with the opposite side. So here in the same area, we were able to see slightly hyper. I cannot label it hyper because it depends on which color scheme I'm using. It is just a gray matter, white matter differentiation, which is significant or not. And that is how, as I showed earlier, in this case, patient, it helped. So ratio image was able to help us in this case, but not in the earlier case. Still, both cases were surgical cases, even though ratio. So as I mentioned earlier, ratio and gradient image or the texture image, these are not the tools for confirmation for going ahead with the diagnosis, but they may help in confirming whatever we are seeing, whether it is obvious or not. So PET scan showed us this, and because we had a doubt about hippocampus, mesial temporal, so we went ahead and did a PET asymmetry analysis. So PET asymmetry analysis confirmed the lesion what we saw. The area of hypometabolism was seen in that same area. So the surgical plan was that we went ahead with surgical resection, ECOG guided. And after that, we also sampled hippocampus during the ECOG. Hippocampus was not firing, so we left it alone. And this patient turned out to be focal cortical dysplasia type 2A. I'll just stop the share and I'll show my final slides. So this was the area which we suspected. Again, on FLAIR, we had a probable diagnosis. On gradient image, we see that the ribbon is lost. So it appears to be dark. It is a learning curve. I mean, just because I'm showing it doesn't mean that you have to agree with it. So it is slightly operator based or the viewer based. There will always be a bias, but we were pretty convinced that it is there, and we confirmed with the ratio image here. PET, same area confirmed. PET asymmetry. So we went ahead with that. So I would like to give some take-home messages. And the most important is that please look at the MRI in the software. Don't look at the images in case you are suspecting a focal lesion. Second thing is don't label the patient MRI negative till it's confirmed on harness epilepsy protocol. Be it 1.53 or 3 Tesla, it doesn't matter. Even Montreal Neurological Institute had 1.5 Tesla, the ones who developed these all techniques. So it doesn't matter. They were picking up all those lesions on 1.5 Tesla. So insist on DICOM images, review in appropriate software. And as I mentioned earlier, it is unlikely to be a partial volume effect if the lesion is seen in all 3 planes. If we can convince our team about the lesion, there is probably a lesion. and order PET generously in MRI negative focal epilepsies. PET MRI co-registration helps in confirming the lesion. And if it's focal, probably there has to be a lesion. That is what we believe in. And all the softwares which I used were these softwares, ITK Snap, MyPav. Horos is a good software for MRI viewing, Mac OS only. MATLAB is a paid software you can use for MRI post-processing. SPM Toolbox works only in MATLAB. 3D Slicer is a good tool to mark the lesion, which I showed earlier. So after marking the lesion, it is good to convert from NIFTY to DICOM and DICOM to NIFTY. ITK Snap also helps in conversion of those images so that these images are readable to the MATLAB and other software. So we need to know about DICOM images. We need to know about NIFTY images. It is very simple. You just have to read about it and you will understand. And I have a website, epilepsymri.com. I have provided the link to all those tools on that website. So you can go on that, epilepsymri.com, and you can get all the tools and harness epilepsy protocol and everything else. Thank you.
Thank you, Dr. Rutul. That was an amazing presentation. You gave us an inside view of what exactly work looks like for an epileptologist. And while also telling us that epilepsy work is doable wherever you're sitting. And we just should know at what point of time we should step up and or manage. So at this point, we have 2 more presentations awaited. And then I thank you again for this wonderful presentation. I wish you the very best for your future epilepsy work. Saraswati, I think we can take over the next. One question by Dr. Sumant in the chat box. One of the moderators can answer it. And we will move to the next presentations.
Thank you, Rutul. Thank you, Vinay sir.
Thank you.
I would like to welcome Dr. Aditya Nair sir, Professor of Neurology from CMC Vellore, to please take over the proceedings, sir.
Thank you, Dr. Saraswati, for giving us institution the opportunity to present for the IAM Young Neurology Forum. I'd like to invite Dr. Angel Miraclin, the Associate Professor in our institute, to introduce the speaker.
Yeah, good morning, everyone. Thank you, Dr. Saraswati and Dr. Jyotsna, for giving us this opportunity to present in this forum. So we have 2 interesting cases from our side. I called Dr. Bhargav, who's a senior resident in neurology, to go ahead with the first case.
Good morning, everyone. Myself, Dr. Bhargav from CMC Vellore, senior resident. Now I will be presenting a case titled Spark, Starvation and Senescence, an uncommon cause of late life seizures.
Can you make it slideshow mode, Bhargav? Yeah, thank you.
I'll be starting my case now. So our patient is a 65-year-old gentleman from Vellore, presented with new onset seizures. He was well till 5th October 2025 when he had transient episodes of sensory symptoms in his right upper limb and lower limb, and that lasted for a few seconds to minutes. And then 2 days later, he again had similar complaints in his right leg as well while he was resting on the couch. Then he got up and lost his consciousness and fell on the ground. The wife subsequently noticed uprolling of his eyeballs with tongue bite and posturing of his limbs. He was then taken to a nearby hospital with 2% support. However, by the time he reached the hospital, he regained his sensorium, but he was in a confused state. He was then given the loading dose of levetiracetam in that hospital and was then referred to us. He came to our ED. There was no prior history of any fever, rash, drug abuse, or native medication intake. And there is no prior history of any encephalopathy or seizures before this current episode. Recently, he was diagnosed as a hypertensive, but he was not on any medication. And he was a reformed chronic smoker as well. So by the time he reached our ED, his vitals are stable, except for the elevated blood pressures. And he was in a confused and post-ictal state with GCS of 14/15, and other examination findings are unremarkable. So summarizing the case history, he is the 65-year-old gentleman presented with new onset focal seizures in the form of right-sided sensory symptoms with secondary generalization. Clinical localization was to the left cortex.
So at this point of time, you can put in your thought processes. This is summarizing an elderly gentleman who's coming with a new onset focal seizures. And it's both the episodes are quite stereotyped to the same focus. So these were our thoughts. Anything else anybody would want to consider specifically in this? So because we're presenting this case in a forum, we would also think of neurological rarities also, because we wouldn't present something very common. So these are the common things which you consider. You can just put it in the chat box. Any other specifics, would you keep it in the differential? Okay, not getting any response, but yeah, we can go ahead. Yeah, Bhargav, continue.
So based on the history and clinical examination, at this point of time, we considered the differentials for a new onset focal seizures, especially in the elderly male. So the possible causes we thought were structural causes like intracranial space occupying lesions, other causes like cerebrovascular accidents, including the embolic strokes, which can present with seizures at the onset, and also a probable CVT also with intralobar hemorrhage causing the seizures. And other differentials like metabolic seizures due to hyperglycemia or hypoglycemia or hyponatremia, and other things were like CNS infections were also thought of. So we did an imaging from the ED, which showed diffusion cortical hyperintensities in the peril and Rolandic region, and there is, however, no diffusion restriction seen. And T2 flare images showing bilateral caudate and putamen hyperintensities and bilateral symmetrical, near symmetrical cortical hyperintensities in the peri-Rolandic cortical regions.
So we have expert neuroimaging panelists also. So, I mean, how would you describe these lesions? What else would you think of? I think somebody had mentioned in the chat autoimmune. So, GABA related. Yeah, that's a good thought process. Anything, Dr. Aditya, from your side, what do you want to say? I think I'm muted.
Yeah, thank you, Injil. I think we were little struck by the peculiarity of the MRI that he had come with definitely a focal sensory symptoms and then has gone on to develop multiple episodes of seizures. So clinically, we were expecting a unihemispheric and more cortical dominant presentation. We were really struck by that there were multiple lesions and some changes even in the basal ganglia, which clinically the patient did not have any clinical correlation with. So as already suggested by Angel and the other panelists, and we are also considering relatively broad differentials at this point in time. In fact, the initial read from the casualty MRI was even considering, because of the high blood pressure was atypical press and all those things, which we were considering as a little less.
Yeah, thank you for that. So that was the catch here. Like though the symptoms were localizing to a particular hemisphere, we are seeing bilateral findings. So any thoughts on what else could it be? Again, autoimmune, very high up on the cards. Anything else? Yeah, so Bhargav.
So there is no significant blooming on the SWI-GRE sequences, and there is no post-contrast enhancement as well. So we had done the lab parameters. All the lab parameters, basic proteins were normal. Serum ammonia was normal. We went ahead and did the CSF analysis, which was unremarkable. CSF lactates were borderline mildly elevated, and EEG showed a focal slow wave dysrhythmia restricted to bilateral temporal regions.
So at this point, any like in the chat box, primary angiitis of the CNS. So anything for or against? How do you discuss that, Dr. Aditya or Dr. Bhargav? You can.
Yeah. I think these are interesting possibilities that have been considered. It's a diffuse cortical lesion. I agree, angiitis could be considered as a differential. However, we felt that normally they generally present with more subcortical lesions, some more SWI microbleeds, some meningeal enhancement we would have expected. in the prior images that Dr. Bhargav was showing, we really couldn't appreciate any significant microbleeds in the basal ganglia and high cortical regions, and we really couldn't pick up any significant visual enhancement. So yes, we considered those differences, but we had kept it less likely. We were still working after the diagnosis here. Over to you.
So again, something against a systemic problem, all the basic bloods did not give us much clue. And whatever the metabolic screening, including ammonia, was actually normal. Yeah, there's a good thought whether it's all post-ictal, but whether when you see bilateral findings and why should the basal ganglia bilaterally light up? So these are our questions at this point. So we did consider mitochondrial cytopathies as one of the higher differentials, but again, what is against it? He's aged. And he's never had similar events, and the CSF lactate was borderline. So this is where we are. So we'll go on with the discussion. Bhargav?
Yes, ma'am. So at this juncture, based on the history and radiological findings, we considered atypical breast because the presentation BP was very high and he was recently diagnosed hypertensive also. And there were also near symmetrical cortical hyperintensities are there. Atypical because the white matter is not much involved, more of hyperintensities we could see in the gray matter region. And second thought process was any toxic intake, toxic encephalopathy was also a consideration due to basal ganglia involvement. And third thing was whether it is any arboviral, atypical arboviral infections, including the Japanese encephalitis. And the fourth probable consideration was autoimmune encephalitis. Though it is an old age patient, we thought as a last differential autoimmune encephalitis as well, particularly the GABA B or A receptor encephalitis and LGI encephalitis as well.
So there was also a consideration of SREAT. That was a good thought from in the chat box. So that also could be a possibility. But his age, 65-year-old, we usually consider the LGI1 spectrum at this point. Again, SREAT could also be, or a paraneoplastic encephalitis. All those were our considerations. Can go on.
So accordingly, we worked up the patient and all the serologists, including the autoimmune panel, NMO serologists, and vasculitic workup, and it was negative. And we went and did an PET CT whole body, which showed hypometabolic areas in the cortical lesions, and the rest of the PET CT was negative for the apparent malignancy or infective focus anywhere else in the body. So in view of all the negative workup, including the infections and the immune workup was being negative with atypical imaging findings. Further, we went ahead and asked the patient relatives about the further history was probed. So there was he was born out of a third-degree consanguineous marriage, and he attained normal milestones at birth. And he had 10 siblings. 4 brothers and 2 of the sisters have similar kind of seizure episodes, and they were not fully evaluated, and all have succumbed to their illness. So this is the detailed family history of the siblings. So in view of the
So Bhargav, can you go back to the family history and just tell what each of them had, and just briefly, so that
yes, ma'am. So the first elder brother had memory disturbances right from his 65 years of age, and he died due to 75 years. Like current our patient's presentation, he had similar kind of seizure episodes and was not fully evaluated, and he succumbed. And second brother also had seizure episodes, complaints of seizures, and he died at very young age, and he also had a cardiac disease, congenital heart disease as well. And third brother had sudden cardiac arrest. And fourth sister died. Probable etiology was not sure from the relative side. And fifth brother was also a young death due to an unknown reason. And sister died of smallpox. And seventh sister had illness similar to our patient. She also has the seizures. Outside, they labeled her as probable TB meningitis, and she also has succumbed. Eighth brother had deficits since birth, slurred speech, writing difficulty, and also he too had the seizures, and he succumbed at around 54 years of age. And ninth sister, similar to our patient only, and her age of symptom onset was at 25 years of age, and at around 60 years of age, she has some illness and worsened. And 10th is our patient.
Thank you.
I think it's important to
Hmm.
note here that we didn't have, though they brought up this history on further probing only. I mean, we are not really looking at family history as a first historical question that we asked for patients, especially at 65, was having their first episode of seizure. So this was quite a shock to us when we brought up that there were similar illnesses in the past. Some of them had an encephalitic-like presentation, or some of them were having some issues from birth. So this was a little odd. However, we didn't have any details or records, or the family didn't have any records of how each of these patients had died, what were their imaging findings at any point in time. So we only knew that there were significant neurological issues in the family, but we didn't have records of that.
Yeah, thank you, Dr. Aditya. So again, so the attendees, you can think of what could be the possibility. Yeah, so majority are saying mitochondrial malas. Yeah, so we did consider that, but the hallmark is in the pattern of family history, we see three types of involvement. Like majority were having seizures as a unifying feature in all of them. And some have been diagnosed with query brain fever. So we presume it's like an encephalitic, or like what Dr. Aditya said, an encephalopathy is one more thing which is striking coming up. And there is some involvement of the heart also in some of the next generation. So these are the things which actually are standing out. Like what we said, even at 65, this case actually taught us the value of, getting into family history. In fact, we didn't do it upfront. We did it quite later into the admission. So, yeah, Bhargav, over to you.
Yes. So, in view of the near symmetrical cortical and deep gray matter hyperintensities with focal onset symptoms with a significant family history, we thought of a mitochondrial disorder also. So, genetic testing was sent both for the whole exome sequencing and also mitochondrial genetics were sent. And the patient was subsequently discharged on anti-seizure medications, and he was given the mitochondrial cocktail supplementation. And the genetic results are awaited at this point of time. So next 2 weeks later, he came to our OPD with worsening symptoms 2 weeks after the discharge, with worsening of gait, with new onset slowness and tremors in his hands and drooling of saliva. However, there were no triggering factors like any intercurrent illnesses, fever. We did the infectious screening at that point of time in the OPD visit, and the inflammatory markers both were negative. And we did a repeat imaging at that point of time, which showed now bilateral basal ganglia hyperintensities involving the caudate and the putamen, and bilateral hyperintensities in the cortical regions, in the bilateral parietal regions. However, there is no diffusion restriction. Flare hyperintensities, cortical hyperintensities are also seen in the flare. So then we reviewed the medication. Then it was noted that the thiamine was not administered in this patient.
Okay. So, Dr. Aditya, do you want to comment on this? So what actually, so we usually have this mitochondrial cocktail. So we have multiple coenzyme Q, NAC, and all those things, acetylcarnitine and all the riboflavin at high dose, pyridoxine, biotin, thiamine. It's all added and given to them. So what was actually not missed in the prescription for him was thiamine. So did that actually matter or not? Dr. Aditya, would you like to comment?
I mean, this is a case that we were all involved in the clinical care of. So it was little surprising for us when he had actually come to OPD with significant worsening in his symptoms. He actually almost came like now with symmetric Parkinsonism, tremors, and drooling of saliva, almost looking like a osmotic demyelination, like a pontine extrapontine myelinolysis like clinical presentation. So we actually were really struck by why he was worsening despite giving a cocktail. Was it just the disease which was progressing, or was there a second trigger that we had missed, or even whether the primary diagnosis was correct? We had repeated some of the metabolic parameters, and that was also found to be normal. And the only thing that we found in the medication was that this particular medicine called thiamine was missed. So this was subsequently, at this point in time, we are still pending genetic reports. As we all know, with our experience, that it takes 2 to 3 months is the turnaround time that we have for genetic reports. So at this point in time, the only thing that we could find out was in the cocktail that thiamine was not administered in the thing, which was added at that point in time, considering now there is significant worsening in the symmetric basal ganglia lesions and new white and gray matter lesions which are present.
Yeah. Thank you. Bhargav, can go on.
Yes. So this was the latest imaging, follow-up imaging. He came to our OPD recently 1 week back. So after the time of he took the thiamine supplementation after the last visit, and this time the imaging showed near complete resolution of the lesions which we saw prior, and there is no recurrence. Symptomatically he was all right, and there is no recurrence of seizures also. So the genetic analysis report has come. Mitochondrial was negative, and the whole exome sequencing showed homozygous missense mutation in the exon 3 of SLC19A3 gene that resulted in amino acid substitution of glutamic acid to valine from valine at codon 121. This was detected, and the phenotype was thiamine metabolism dysfunction syndrome type 2, biotin thiamine responsive basal ganglia disease.
So I think a couple of people in the chat have already, the last two have gotten the diagnosis. So this was quite a learning case for us, not for the complex aspect of it. It's just a simple message of, getting into the family history. And it required, Dr. Aditya was the one who actually picked up in the OPD what had caused this worsening. In fact, compared at discharge, he was quite stable. So it's a practice that somebody comes with seizures, we always administer as IP, we give IV thiamine. So probably that was the thing. And to figure out among the huge list what was missing and restarting that actually made a difference. So we didn't have to wait for the genetic report to actually treat this patient. So it's a case that that would be the take home message. So over to Bhargav. Dr. Aditya, anything do you want to add on?
I think the thing that we were actually considering mitochondrial as as it was initially discussed with heart disease and other multi-system kind of involvement. We were thinking more in the form that this is likely a mitochondrial disorder. So we were actually relooking at the anti-epileptics if mistakenly any valproate or anything was given which had kind of triggered off the second thing. We really couldn't find any other febrile illness or other trigger which could have caused this worsening. So I think for us it's a learning point that even at 65. We are thinking this is significant because this imaging and clinical presentation was suggestive, and the response to treatment has shown significant response. As we know, biotin thiamine basic ganglion disease doesn't have any serum marker for us to look at, unlike say biotinidase where you can do serum levels. Here at a routine clinical practice level, we do not have any serum markers to confirm our enzyme assay. However, at 65 to have still not having any prior episodes of seizure, to have a primary presentation like this was definitely a learning point for all of us.
Yeah, Bhargav, you can complete your presentation.
So coming to the pathophysiology of the disease, SLC 19A3 codes for the human thiamine transporter 2 protein, which is required for the transport of thiamine into the cytosol. So when there is defect in this gene, missense mutation or deletion, the transport protein cannot work properly, so that the thiamine metabolism doesn't happen. So this results in defect in the conversion of pyruvate to acetyl coenzyme A, which is the initial step to start the Krebs cycle, TCA cycle. So this will be hampered, thereby the TCA cycle cannot happen. So administration of thiamine is utmost important, and also there is a supplementation of biotin showed that pyruvate to oxalate conversion can happen through carboxylation reaction. Thereby the oxalate fuels the TCA cycle, and thereby entering into the TCA cycle and will be completed. So biotin and thiamine are the responsible vitamins in this condition to supplement the TCA cycle. So this is how the biotin plays a role in conversion of pyruvate to oxaloacetate. Thereby the oxaloacetate fuels the citric acid cycle, TCA cycle, and thereby generation of ATP and takes it further. So there are three phenotypic spectrums of this disease. One is early childhood encephalopathy, which was first described, and early infantile form and late onset Wernicke-like encephalopathy. In early childhood encephalopathy, the mean age of onset is 7 years, the patient presents with episodic encephalopathy with neuroregression and recurrent seizures, spasticity, and extrapyramidal symptoms like severe dystonia, gait dysfunction will be there, and behavioral issues. And early infantile form has very poor prognosis and has even poor response to thiamine and results in premature deaths. It presents as a rapidly progressive encephalopathy with seizures, lactic acidosis. And late onset Wernicke-like encephalopathy presents with acute onset neurological symptoms like seizures, nystagmus, ophthalmoplegia, and ataxia. And it shows a very good response to high dose thiamine and biotin supplementation. So whenever we see the imaging characteristics showing bilateral symmetrical lesions in the caudate nuclei and putamen and especially the medial thalamus also with variable extension to the brainstem and cerebral cortex and cerebellum. So we have to have a diagnostic suspicion of this neurometabolic disorders. In this condition, especially the globus pallidus is typically spared. And there is also absence of significant contrast enhancement won't be there in this condition in the imaging. And how to differentiate it from the Wernicke encephalopathy is mammillary bodies will be spared in this condition. And more important is that there will be extensive cortical involvement as we have seen in this case. So it's a treatable neurometabolic condition. So at the admission, the intensive care support should be very good. And if at all ventilator requirement, we should give the patient, and treatment of seizures is utmost important. And we have to rule out any triggering factors like fever prior to the onset of the symptoms, and that has to be ruled out and that has to be treated if at all it is there. And the cornerstone is giving the vitamin supplementation at high doses like thiamine at 10 to 40 milligrams per kg body weight. Adult dose will be at 600 milligrams per day. And biotin is initiated at 5 to 10 mg per kg body weight per day. And treatment should be lifelong. And we should avoid the drugs that impair the metabolism of the thiamine like metformin, verapamil, chloroquine, and famotidine should be avoided in the patient. So it's an unusual feature in our patient was late presentation at around 65 years of age, because the prior reported cases were at middle or engaged people were seen. And the detected missense variant may partly explain this phenotype, because missense mutations are often associated with the residual protein function and has very good response to biotin and thiamine therapy, in contrast with the frame shift mutations or the deletions or the nonsense mutations, which typically produce more severe disease than missense variants. And this residual activity may have contributed to the delayed onset of the disease in our present case. So finally, the take-home message is it's a treatable neurometabolic disease, and we should think about biotin thiamine basal ganglia responsive disease, basal ganglia disease, when we see the typical history of seizures with Wernicke-like presentation and leaks like MRI imaging. So the disease responds to very high doses of thiamine and biotin. And this case expands the phenotypic spectrum of SLC19A3 related disease into the 7th decade and highlights the importance of empiric vitamin therapy in this kind of atypical adult presentations.
Thank you, Bhargav. Thanks for that. Any questions? We are happy to take. Any comments from the panelists? Dr. Saraswati, Jyotsna, you can.
I think a very important message from here. So otherwise, we'd have just made it as autoimmune or paraneoplastic and then given IV steroids, rituximab, plasmapheresis, etc., so on and so forth. So it's really a striking family history, which I think which has probably guided to diagnosis. Otherwise, very, very tough to pick up such case at 65 years. And probably in many settings or would have just gone on steroids, rituximab, etc. I'm very sure about that.
Thank you.
Very true, Dr. Saraswati. We would have also considered the same. I think the family history was the clue here in helping us in the diagnosis.
Any other comments from the panelists? If not, we'll move on to the next case. All right. Somebody had mentioned Leake's disease in childhood. CSF lactate was high. Any particular reason? So, Dr. Aditya, do you want to say that?
And these are non-specific markers. I mean, there are case reports where CSF lactate has been found. These are finally energy failure syndromes. even like the cortical basal ganglia kind of involvement, are just that the highly metabolic cells are not able to, the high metabolic activity cells are having significant problems. So lactate has been found to be high in serum and CSF, and also has been also been found to be low. So it doesn't give us any diagnostic markers here in these kind of cases. Similarly, urine organic acids have also showed some lactate metabolites, but again, not diagnostic in any particular form.
So,
That was yes.
yeah, sorry.
That was
please go.
recurrent seizures, like how we see some cells with patients having recurrent seizures, whether it was because of that.
So any previous history of encephalopathy in this patient? Bhargav, would you want to answer that?
No prior history of any such events, ma'am. No prior encephalopathy, no seizures in this patient prior
Yeah,
to.
so that was the catch. Actually, after getting the family history, we went back to his past. We kept asking them whether there was any hospitalization, anything at home you had managed. So unfortunately, this was his first presentation. So, all right. So shall we move on to the next case? Now, may I invite Dr. Hemant, senior resident in neurology, to present the second set. Hemant, you can Bhargav can stop screen sharing, and Hemant, can you share your slides? Can you unmute yourself, Hemant? Yeah, and put it in slideshow mode.
Good morning, everyone. Am I audible, ma'am?
Yes. Please go on.
Good morning, everyone. Thank you for giving this opportunity to present a case today. Topic for today's discussion is brain on fire. Myself, Dr. Hemant, senior resident in Department of Neurology, CMC Vellore. Coming to the first case, here is a 34-year-old lady who's presented with from Jharkhand, presented with chief complaints of headache 1 month duration, followed by language impairment since 1 week. Coming to the details of the history, patient was apparently well in the month of October 2025, and she started initially having a headache which was predominantly left-sided, unilateral, intermittent in nature initially, and dull aching character. There was no associated any photophobia, phonophobia, or any vomiting or any visual aura. And she had a symptomatic improvement initially with analgesics. But after 2 weeks, she continued to have persistent headache, which was bilaterally and with minimal response to analgesics. And later on, the family members over the next 1 week also noticed some language impairment in the form of she started becoming mute, like reduced word output while having a conversation with the family. And she also started having difficulty in finding the name of the close relatives and difficulty in understanding the conversations. And there were also episodes of confusional behavioral. Like there was one such event where while traveling to CMC, they had she got lost in the train and requiring the family's assistance to get back to the compartment, and they were total duration was 1 month, but there was no history of any seizures or history of loss of consciousness. There was no history of any weakness of limbs or any sensory symptoms involving the extremities. There was no dysarthria and there was no double vision, and there was no history of any systemic symptoms like fever, malaise, cough, or breathlessness, or weight loss or decreased appetite. Past history, she had no known comorbidities and she was not on any regular medications. At presentation, her vitals, she had mild tachycardia, blood pressure was normal, and GCS at arrival was E4, V2, M5, that she was not verbalizing. Coming to the language assessment, her fluency, naming, repetition was impaired. Simple comprehension was impaired, intact, like single pointing to objects are intact, but the complex comprehension was impaired. Other memory examination was not able to assess because of her language impairment, but she didn't had any dysarthria or anything. Other cranial nerve examination, fundus examination was normal, extraocular movements were normal and full. There was no any nystagmus, and pupils were equally reactive to light. There was no any facial asymmetry. There was no other cranial nerve deficits. Motor system examination revealed normal power in all 4 limbs with bilateral flexor plantar, And other domains like there was no gross sensory impairment or any cerebellar dysfunction. And there was no any neck stiffness or other meningeal signs. With this, language impairment was a predominant focal deficit which we found out on examination, and there was no features of meningitis. So coming to the summary, here is a 34-year-old lady who was presented with progressive symptoms of 1 month duration, initially to begin with a headache followed by language impairment. With this, we'd like to localize to the left frontotemporal cortex. And has she presented with a progressive 1 month history of headache with the focal deficits? We consider first one of the differentials as infective. Any like bacterial, partially treated bacterial meningitis or tuberculosis was considered among the infections, or any space occupying lesions like tumefactive demyelination or lymphoma or low-grade glioma was considered. Other differential which we consider because was CVT, which was less likely as she had a progressive symptom of 1 month duration with not much features of raised ICP. With this, we did the initial evaluation. MRI brain was done. As we can see, it showed this is a T2 axial flare sequences showing predominant left temporal and frontal guidal swelling, also involving the part of a parietal lobe, with corresponding T2, T1 post GADO images showing subtle leptomeningeal enhancement. With this background, as we consider the infection as one of the differential, we also did, because she had episodes of intermittent confusional state, ongoing non-convulsive seizures was also considered, and EEG was done, which as we can see, EEG showing intermittent generalized slowing with predominantly over the left temporofrontal region compared to the right. And considering the infection as one of the differentials, CSF was done, which showed pleocytosis, that is of 110 cells, neutrophilic predominant, and glucose was low. CSF glucose was 45, corresponding serum was 70, and protein was mildly elevated of 71 milligram per deciliter. The initial infective workup was negative for multiplex viral PCR, and bacterial cultures were negative, and TB gene expert was negative, and cryptococcal antigen was negative. Cytology also didn't show any atypical cells. And with this, CVT and the other space-occupying lesions was ruled out, and blood parameters showed elevated inflammatory markers.
So at this point of time, any thoughts? So we can just go back to your original slide, Hemant. Yeah, the summary. Yeah. So with this pattern, summary slide. So this is not a static, it's a progressive disorder, and with onset with a headache. So and a cognitive syndrome with imaging also being abnormal. So again, because we're presenting, it's always wise to think the common as well as the uncommon ones in the forum. So any thought process, anything in the chat? Okay, nobody's put anything so far. Dr. Aditya, any comments from your side?
Yes, it's a progressive meningoencephalitic like illness was a consideration here. And there was some fever, low-grade fever, and some intermittent confusion which we were considering whether it was part of seizure. So a progressive meningoencephalitic like syndrome, person coming from who has come to us as all option respective. And so in that kind of a CSF picture, we would always consider a infective process first. I think we will be discussing what are the and with the preliminary infective workup being negative, we will need to look at other differentials also, I think.
Yeah, so now the chat is quite active. So why was autoimmune encephalitis not considered as a DD? So because considering the fact that she had some fever, headache, and a cognitive syndrome, always an infection, comes on top. Good thought process, HSV to NMDA encephalitis transition. That is also a good thought. Some have also put flames, smog related, and viral markers. So we proceed with further, proceed with the presentation. Hemant.
So yeah, patient was initially, we also did a whole body screening to rule out any systemic infections, which was negative for systemic infection or other granulomatous disease. And it did show brain hypermetabolism in the corresponding left frontotemporal regions, as you can see this PET brain image, axial images. So based on this initial clinical presentation and evaluation, she was treated initially with for infective etiology with IV antibiotics, antivirals, and other anti-supportive measures, including anti-seizure medications. But patient didn't show significant clinical improvement. And as a other differential was a tubercular meningitis. She was also started on empirical ATT, and we did evaluation for the other etiologies like inflammatory etiologies, and a serum autoimmune panel was sent, which was negative for the common autoimmune encephalitis. And as this patient has presented with CSF pleocytosis with PET brain showing hypermetabolism after ruling of the common infective and neoplastic etiologies. Other inflammatory disorders were also considered, and serum workup for the NMOSD and MOG was sent, and which came out to be serum MOG of 1+ positive and CSF was 2+ positive in this patient. With this initial evaluation and clinical presentation with MRI brain showing typical T2 flare hyperintense lesions, a cerebral cortical encephalitis with a MOG antibody positive flames was considered, and she was also had a minimal response to steroids, which was started along with the empirical ATT, hence confirming the diagnosis of improbable underlying inflammatory etiologies. And she was further treated with the IV methylprednisolone pulse therapy, and following which she showed a significant clinical improvement at 3 months follow-up. And also there was a radiological improvement, as we can see the 3 months follow-up MRI T2 flare axial images showing resolution of the guidal edema. So with this, we'll like to go ahead and present the case 2. He's a 30-year-old gentleman who also presented with only new onset recurrent focal seizures. Coming to the semiology of seizures, he presented with behavioral arrest, staring look, and irrelevant speech, followed by generalized seizure, last for 2 to 3 minutes, and followed by postictal confusion, with no postictal weakness or any prior headache. There was no any prior fever. Patient was evaluated and outside hospital and treated with anti-seizure medications, but he continued to have further seizures in spite of being on adequate anti-epileptics. At presentation to hers, his examination revealed normal with no focal deficits. And an MRI brain was done, which did, as we can see, the T2 axial images showing flare hyperintense lesions involving the left, right temporoparietal and occipital region, with also part of the frontal region. And there is also T2 flare hyperintense subcortical lesion involving the corona radiata and internal capsule on the left side. And T2 1 post-gadoaxial images showing subtle leptomeningeal enhancement in the corresponding flare hyperintensities. With this imaging, so is a 30-year-old, coming to the summary, 30-year-old gentleman who presented with new onset recurrent focal seizures with secondary generalization with normal neurological examination. As a patient has presented with a semiology of behavioral arrest with a irreverent speech followed by generalized seizure. The probable localization considered was a non-dominant hemisphere, and also that is a right hemisphere. And there was also radiological evidence of right involving the right frontotemporal cortical swelling.
So, contrasting with the previous patient, what unifies both of them is more like an encephalitic presentation, and it's a focal hemispheric localization. The first patient had more of a confused behavior, which is either part of the cognition itself or it's part of a seizure phenomenon. Her EEG was abnormal. In him, 2 discrete episodes of seizures, but again, imaging being abnormal. So the unifying is an encephalitic presentation. So always an infection on top. And the second thing would be an inflammatory. Dr. Aditya, anything would you want to add on?
I completely agree with like what AJ suggested. In fact, for the second case, we were actually had in the initial MRI had missed the subtle right occipitotemporal lesion. In fact, what was striking was the subcortical lesion on the left, which we couldn't explain the seizure, the cortical event, the seizure actually required us to relook at the imaging a little more closely to pick up that cortical lesion and subsequently direct investigation. In fact, he was actually labeled, the second patient was actually labeled as a CNS lymphoma elsewhere and had actually come for a second opinion on that. So I think various differentials and various diagnoses can come with such similar presentations.
Okay, go on, Hemant.
So we did a further evaluation, including the CSF as a focal cortical encephalitis was considered, but it showed cells were normal with normal glucose and protein. Other blood test, immune workup and metabolic profile was normal, and EEG was normal. And we also did a systemic screening with the PET whole body, which didn't show any other systemic active lesions. But the PET brain did show hypermetabolism involving the right frontal and parietal and temporal regions in the corresponding to the brain images. And with this, after ruling out the common infections as a multiplex infective workup in the CSF was negative, other differential for focal cortical encephalitis, inflammatory and immune mediated was considered. An immune workup was sent. It showed ANA of 3+ and with elevated CRP, and serum autoimmune encephalitis panel was negative. We also sent a NMOST screen, which came out to be MOG antibody positive, and hence a diagnosis of flames was considered. That is, a flare hyperintense lesions with anti-MOG associated encephalitis with seizure was considered, and he was treated initially with the IVIG and followed by steroids and rituximab. And he did show significant clinical improvement at 3-month follow, and there was both clinical and radiological improvement, and he was seizure free.
Yeah. So I think there was a question in these cases, CSF NMO-MOG versus serum NMO-MOG, which has more sensitivity. So as of what I understand, serum is the best for detecting MOG. So higher concentrations are actually typically seen in serum than in CSF. The role for CSF then comes in the seronegative cases where some 11 to 12% patients who have like high clinical suspicion, they can have CSF might test positive, and later on serum might show up also. So that is what, Dr. Aditya, any comments on that?
I think definitely as you suggested, but I think it also depends on what kind of a assay we are using in testing the MOG. I think in research lab centers, they have a live cell-based assay, which is able to look at the MOG protein in the full natural 3D conformational epitope. So you get better results, while most of the commercial lab kind of immunofluorescence cell-based assay, which is fixed cell-based assay, sometimes can miss it. So I think it depends on what kind of a setting that you're working on. Maybe Dr. Saraswati or Dr. Jyotsna can add more to it.
Yes, sir. MOG, always we have this problem of so many cases being false positive. As you rightly commented, the cell-based assays are the one which are which should be used whenever we have doubt. I think Anita madam is there in the session, but I'm not sure how can I call her into the panel. Madam would be best in answering this. But I totally agree with you, sir.
Sorry, I'm muted. Yeah, we'll continue, Hemant. Yeah.
So coming to a brief note on this MOG antibody disease, as we all know, it's a CNS inflammatory disease with antibodies against the myelin oligodendrocyte glycoprotein on the surface of the oligodendrocytes and myelin sheets. It's present with a distinct CNS inflammatory disease, both typical and atypical manifestations. It's usually monophasic illness, can also have a relapsing course. The typical clinical spectrum of presentations include the optic neuritis, myelitis, and Adam-like illness of brainstem syndrome. The other atypical spectrum which is evolving includes encephalitis with seizures or isolated cranial nerve deficits, clippers, or a leukodystrophy-like presentation in children's. Coming to the diagnostic criteria, it's mainly includes the core clinical demyelinating event with a positive antibody test after excluding other diagnoses, including multiple sclerosis. The core clinical demyelinating events includes optic neuritis, myelitis, Adam-like illness, and brainstem or cerebellar deficits, cerebral monofocal or polyfocal deficits, or cerebral cortical encephalitis with seizures. Along with one of these clinical features which we have a clear cell-based assay serum being positive, no additional supporting feature is required to diagnose a MOG. If there is a low positivity or low titers, we need to consider the other supporting features for the considering MOG encephalitis. Coming to the cerebral cortical encephalitis phenotype, it is a recently described entity from 2017, where the 47 persons were misdiagnosed as a focal encephalitis was treated with antibiotics. And one of the cohort done in a Mayo Clinic, which showed the predominant age group was the children, and the predominant clinical features they present with the headache, fever, seizures, encephalopathy, and focal cortical dysfunction. And the pathology, how it is different from the typical MOG, is where it is a predominant leptomeningeal inflammation with microglial infiltration, along with they can also have extensive subcortical subpial demyelination. And the imaging characteristics which is little different from compared to the typical MOG is that predominant cortical flare hyperintensities with leptomeningeal enhancement, and which is different from the typical MOG where we can find both cortical, juxtacortical, and subcortical deep matter hyperintensities. They can also have associated brainstem lesions. Whereas in the atypical like cerebral cortical encephalitis, they may have isolated only the cortical guidal involvement, and subcortical lesions may be there, and they're usually hypointense. So it's presence with, it's usually unilateral, but bilateral fulminant presentations are also reported, that is more common in children. And with the treatment with the immunotherapy, the seizures and MRI changes are reversible. There is also a newer entity which has been still evolving, that is a fuel, that is a flare variable unilateral enhancement of the leptomeninges. Where among the Mayo Clinic patients, where they described 2 patients who had, when they searched for the patients with predominant leptomeningeal enhancement, there were 2 patients, predominantly children, and who also had an optic neuritis along with the cortical encephalitis presentation, where the imaging showed predominant unilateral leptomeningeal enhancement with minimal to adjacent cortical T2 flare hyperintensities. So how it's different from the flames is they have predominant leptomeningeal enhancement with mild flare hyperintensities involving the cortex. And both the patients had symptomatic resolution of the corticosteroid treatment. Coming to the summary of findings from the literature review, the predominant age group, median age is 28 years and majority of females, and they may have prodromal symptoms including headache or fever at onset, and the seizures presentation is mostly focal motor or focal non-motor, progressing to secondary generalization, and status epilepticus is less described, and the EEG is usually abnormal, may show unilateral slow waves or epileptic discharges. And the typical MRI imaging finding is it's usually unilateral cortical involvement, parietal followed by frontal and temporal lobes. And the other pathognomic feature is a flare hyperintense lesion involving the gray matter, sparing the deep white matter. And they may have 1/3 of patients may have leptomeningeal enhancement. And the laboratory studies may show most of the patients will have serum MOG antibody positive, and CSF may be positive. Other differentiating features is MOG antibody can have CSF pleocytosis that can range from 5 to 599, predominantly lymphocytic, and they can also have mildly elevated protein. And they all respond to immunotherapy, initially steroids and followed by second line. And relapse is usually less.
So another thing to highlight here is if we can just go back. So there are a couple of things which make it more confusing in infection endemic countries. Like we have, tuberculosis and a lot of viral disorders here in like India. So, and we also know that MOG has a tendency to have false positivity in the serum. So if you actually see the first patient, it was a big dilemma whether it was tuberculosis, because she had a significant CSF pleocytosis to begin with, and it's very difficult with PET showing a hypermetabolism and CSF pleocytosis. It's very difficult to actually take a call to go the immune way, which is pulsing and giving rituximab. So what helped us was the strong positivity of MOG both in serum and CSF, which actually helped us take a conscious decision. But of course, it took a while for us to make the decision to pull off the antibiotics and the ATT. But but subsequently we saw the trajectory. Moment we started the immunotherapy, she actually improved. Similarly, I think ma'am has also mentioned in the thing. So intrathecal production. So CSF being positive might give us more confidence, to or on the side of treating it like an autoimmune disorder. So there are a couple of questions in the chat. Why does anti-MOG disease produce both demyelinating syndromes and cortical encephalitis? So I think Dr. Aditya, would you want to take that question?
I think it's, to my understanding, it is still a undefined entity. What is the spectrum that we are seeing? Like even in the two cases that we are showing here, one had a meningoencephalitic syndrome with severe leptomeningeal enhancement in the MRI and severe CSF pleocytosis, while the second patient had lot of but no seizures. While the second patient had lot of seizures, multifocal MRI findings, but the CSF was relatively bland. So and it is often known that these kind of patients can initially present with flames. So, for example, the references that Dr. Hemant has quoted is from the Mayo Clinic cohort. There were these patients subsequently on follow-up after the steroids were tapered and stopped, developed optic neuritis and multifocal ADEM subsequently. We have these two patients we have on follow-up, the first one for at least a year, and the second one for at least 4 or 5 months now. Thankfully, they have not developed any new CNS issue. But I think how and why certain diseases, certain patients present with a certain type of presentation is something that we will have to wait and see and understand more about the disease. Maybe more input from Dr. Saraswati and Dr. Joseph.
Other important thing, another question was, does all patients with seropositive MOGAD need rituximab, like how we use it in aquaporinopathies? So that's again a good question. I think Dr. Ajit is there in the participants thing. So, I mean, I would invite some comments from sir also in the chat box, if possible. Meanwhile, Dr. Saraswati, Dr. Jyotsna, would you want to give any comments on this?
Yes, ma'am. In pediatric MOG, what we have, my experience has been is that they beautifully respond to steroid. And a serial monitoring of VEP and serial MR, we do not see recurrence of lesions most often. Very rarely I have seen MOG going into a relapsing remitting phenotype. Usually it behaves more like an ADEM, one-time kind of an illness. But having said that, it is not a blanket statement like an ADEM where we will never get one. But yes, it is not like aquaporin that we experience in pediatric age group. But I don't have the expertise for adult patients.
I think Dr. Ajit has responded. So response to rituximab may not be as robust in MOGAD as compared to NMOSD and may need steroids, like Dr. Jyotsna's experience as well in pediatric cohort, and slow taper is what. So thank you, sir, for those input. Yeah. Anything, Dr. Saraswati, you want to comment?
No, Anjali, you can please carry on.
All right. Okay. So another question is role of IVIG. So in fact, some of the patients, so we had reported a patient who had a drug-resistant tuberculosis developing an LETM and subsequently having MOG high titers. So in these type of patients, when you have like infection triggering an epiphenomenon like process, like an auto antibody generation because of antigen stimulation from some pathogen. So in these type of cases, we are on the side of IVIG because this lady had a drug-resistant TB. She's already on bedaquiline-based regimen and then develops an LETM at follow-up. So at that point of time, again, we don't know whether it's the immune paradoxical TB worsening. But when we had MOG positivity, we know that it's a classical phenotype of a MOGAD and we are on treatment. So when these infection being a trigger, IVIG would be the best. And Dr. Ajit also had posted, yes, IVIG maintenance would be ideal in these type of patients. And do we need to repeat MOG titers after a while to predict recurrence? I think Dr. Aditya, would you want to comment?
I think the guidelines which has been mentioned is that generally one tends to treat for 6 to 12 months and one repeats the MOG, and if the MOG in the serum comes negative, it is generally considered to be a monophasic illness, and I think one tends to taper the steroids and all. But I think in clinical practice, for most of us, it all depends on how severe was the initial presentation, what is the patient's access to medical care in case if there's a relapse that happens. I think all those come into the picture when we are taking into account when and how to consider tapering. I think, as Dr. Ajit has already mentioned, in fact, the annual relapse rate was much less on the IVIG as compared to mycophenolate, rituximab in MOG as compared to, say, aquaporin, where B-cell depleting therapy seems to be working remarkably well. In MOG-associated disorders, it hasn't really, I think, if I remember correctly, 55% was the relapse rate in some of these patients. So, IVIG has been used in certain situations to be as a maintenance therapy, but again, cost and all those come into the factors here in most of our day-to-day clinical practice.
Agree with sir. We also have some patients where initial 1 or 2 attack, maybe 2 or 3 attacks of optic neuritis within a year, and then now follow-up MOG at the end of 5 years also is still positive, but patient is completely fine. And we have also stopped immunomodulation. So the MOG is a little tricky as compared to NMOSD. So it's all the clinical judgment and how the access, the way we interact with the patients and advise them to immediately come to our medical care. So really quite a few patients who have been for 5 years, 4 years off immunomodulation, but still MOG is positive.
I encountered that too. NMDA, MOG, they all stay. They just stay in the system.
The madam has joined as panelist now. So if we have some inputs from madam and Ajit sir who have joined, I just asked Asmita to make them panelists.
Yeah. Okay, should
I
we?
have a question to ma'am.
Yeah.
Ma'am, titers, how are things evolving in this autoimmune antibody positive spectrum? I want to know if in the near future we can get titer based judgment on clinical improvement. Is that there, or is it just it is there or not there, or strongly positive become weakly positive? And what is your take on that?
Anita ma'am is there.
Yeah, she's joined as a panelist.
Like
Ma'am is
ma'am,
muted, I think.
Yeah, ma'am is muted.
Ma'am declined the request for the panelist, so I gave him the mic.
all right. Okay.
Okay.
Like madam mentioned, right now it's like madam mentioned, it's in dilution that they check whether it's really positive. Even after dilution, if it's positive, that's when they give significance to that. Jyotsna, if that, but actual titers, I'm really not sure, Jyotsna.
Yeah, I was wondering how things are evolving in the future. No? She would know that are we going to have some day where we will get a biomarker or a biochemical evidence for improvement or a remission. Because for now, we are looking at serial VEPs, we are looking at imaging. Giving contrast each time is not easy. So if we get a solid biomarker and a serological, an antibody marker and saying, okay, the titers are coming down, something like that, I just wanted to know. That's okay. So.
Yeah, so Hemant can actually finish the presentation. Hemant?
Yes, ma'am.
Yeah.
So MOG can have other presentations, including the tumefactive.
Are you sharing your screen?
Yes.
I'm not. Are you able to see the slides?
Yes, now it's on.
No.
No, we're not able to see the slides. Just stop and reshare again. I mean.
It's coming as screen sharing is not turned on.
I think the host rights are to be given.
Now you can share the screen.
Yeah. All right. Yeah. Yeah, we can see the screen. Hemant, you can present. Yeah. You're muted.
MOG antibody disease can also have other varied manifestations, among which include is a tumefactive demyelination, which is more frequent than in the MS and NMOSD. And those patients also will have series of pleocytosis. And the other manifestations is a leukodystrophy-like phenotype with a severe fulminant disease, bilateral cortical involvement, subcortical involvement, and with frequent relapses and poor response to immunotherapy. They can also present with a CNS vasculitis-like presentation. Isolated cranial nerve involvement is also described, where the mechanism described is a adjacent spread of the cortical inflammation from the optic nerves or parenchyma, among which the common cranial nerve involved are the oculomotor, trigeminal, or vestibulocochlear nerves, and can also be other disease spectrums are MRI negative myelitis and peripheral nervous system manifestations like a inflammatory low radiculopathy like presentation. So they can MOG antibodies disease is also commonly found to have a overlap syndromes, like the common among which is a NMDR encephalitis, for which a is a MNOS, that is a MOG antibody and NMDR overlapping syndrome, where the patients can present with a MOG antibody like presentation like seizures, demyelination, or they can also have psychiatric symptoms with the movement disorders. And those patients, NMDR and MOG antibody can present, and they're different from the isolated flames is that they have a severe disease manifestations, and cortical abnormalities or flare hyperintensities are less common. And also contrast enhancement is less common. It is also found to have that MOG can have other systemic associations like Sjogren's or SLE, but less when compared to the NMOSD. So coming to the summary, so any patient who was presenting with the acute encephalitis like illness with headache, fever, seizures, and with ICS of pleocytosis, after ruling out the common infections, inflammatory etiologies like flame need to be considered as one of the differential for focal cortical encephalitis, and it can be misdiagnosed initially, and the patients can present later with the other manifestations like optic neuritis or myelitis, and which resulting in a late diagnosis, and can if detected early, it's a treatable disease, and which will have can prevent fatal outcomes and relapse. Thank you.
Thank you, Hemant. I think Ajit sir is there in the panel. So do you want to give some comments on this patient?
No, very nice presentation, Angel. Yeah, same, whatever has been discussed.
Okay, sir. Thank you.
Thank you. Thanks.
Thank you, sir.
Asmita, could you add Anita madam again? Madam is here, I think.
Yeah.
Madam, there were some questions on type of assays used to test MOG, and also their MOG titers or declining titers would help in follow-up of these patients.
I have sent her request to join as a panelist.
I think madam is telling it's not allowing her to re-enter. Actually, we can see madam here.
We can see her on the panel actually.
All right. Right. Madam said madam would type in the answer as madam is not able to join here. Okay.
What we currently have is semi-quantitative assays, isn't it?
Yes.
Like the test.
Yes.
Yeah.
So thank you, Aditya sir and Dr. Angel, for this excellent cases. And the first case was really challenging for every one of us. And the second one brought out this MOG with its lot of controversies and clinical challenges. Also would like to thank Professor Ravindranath sir for giving his time for this session, Dr. Vinay Hegde sir, and all the presenters. We have had an enriching experience today. And we also look forward to meeting you, all of you, again soon. A stroke session will be next on March 22nd. Jyotsna, please take over.
Yes, thanks to all the speakers, moderators, and panelists for giving us your time on a Sunday morning, precious Sunday morning, and enriching our knowledge and sharing your expertise with the young neurologists across India. I take this platform to call for more interesting cases, and all the young neurologists and seniors out there, please support us by sharing, like Dr. Angel did this time, your wonderful clinical cases, and let us all come on this platform. We'll come and grow together and share our knowledge. Thank you one and all. We close this session for today and looking forward to meeting you again on March 22nd.
Thank you. Thank you, everyone, for this opportunity. Thank you.
Thank you. Thank you all.
Thank you.
Thank you.
Thank you. Have a wonderful evening. See you again soon. Thank you.
Bye.
Bye.